Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 206. You're going to watch and learn about complex coronary intervention today, dealing with the left main. You will understand our approach to dealing with calcified lesions. In addition, there are other complexities involved also, and you will learn how best to use imaging for such cases. Before I take you to the Cardiac Cath lab where Dr. Kinney and Dr. Sharma are ready, I'd like to congratulate Dr. Sharma for having been appointed the Chief of Cardiology at Mount Sinai Hospital. I think this is something which has been well deserved by him for such a long period of time, and I am glad that the recognition has been made now. Samin, congratulations. I am sure all our viewers would agree with my statement and they are joining you in your felicitation.
Thank you, Samir, and of course, all our well-wishers. And my biggest well-wisher is our CCC Live. Take this one also. The CCC Live, the audience, which is has swelled up to 30,000 plus every month. And actually, India has superseded now America in terms of audience and viewers. The also has come up with the China. China is already 7%, and we know that China actually with their population, they might also come up very fast. But just we are very happy. The educational mission of the CCC Live continues after its 10 plus, 15 plus years. And Samir, lot to do with your dedication and your efforts into this series, and Dr. Keeney knows that doing the complex cases, and my part basically put together the latest advances of the interventional cardiology at that time. So with that note, and really thank everyone, and we're ready to start. It's a little, it may look a little simpler case on the angiogram, but it may be little. We thought that some tortuosity and some few things. What happened now? Huh? Okay, yeah. So just to say that we try to present some challenging cases. That's how goal has been. Now, many times those challenging cases are real chip complex cases and with LV dysfunction. And this patient is a little different, but in terms of the some tortuosity of the vessels. So with that note, if we can show our slides, this is our CCC live cases, and of course BroadMed AV has been our sponsor for the relay, and learning objective always remains the same. They describe the rationale for appropriate case selection for the planned procedure, then communicate the stepwise approach, and that is the key, stepwise approach to performing complex coronary intervention safely and with an aim of obtaining good angiography and clinical outcome. And of course, apply the principles and lessons from the recent and other recent trials. So the three faculty is still the same, no change. And then these are our supporters, which keep improving and increasing. We like them, and thanks to all our partners. So this is, I said, case number 206, 81-year-old, presented with new onset dyspnea on exertion with CCTA revealing three vessel disease with the high calcium and ctFFR positive in all three vessels. Normal EF, patient has a lot of risk factor, but controlled, as you can see there, does have emphysema, heavy smoker, and BMI is 26. Then this patient is on good medical therapy. Cardiac Cath revealed a calcific three-vessel disease exactly, and distal left main about 50. Then question will be what to do with there. RC was very complex. We did the rotational atherectomy and DES, 2 DES, did well, and were discharged home, aspirin, clopidogrel, and now come back for PCI of the calcified tortuous distal left main and LAD lesion. In terms of appropriateness, these kind of cases will make it rarely appropriate otherwise at the outset, but we know the guidelines that after heart team discussion, those cases become appropriate or by the patient choice. So this patient is that way is appropriate after discussion. So Anu, tell us what's happening.
Let me just go back here. Yeah. So this is the normal EDP. EF is good.
And look at the calcium on the top.
Yeah. This is RCA now. Looks beautiful. And same. Dry cine. tram track calcium, left main. So if you look at that,
Tortuosity all over.
Yes.
all over, exactly. And then circ looks okay. Angiographically, you see the distal circ in the AV groove, small size but moderate disease. So if you see here, this is where I think
Questionable left main, huh?
yeah,
Not
30-50
100%.
left main, and then the significant disease in the prox LAD and immediately after the large septal. Septal and diag size is the same. Looking in the cranial view, maybe there is osteal circ disease, but we'll have to
I
see
mean, a
subsequently.
question for you right up front. Do you always follow the cutoff of 33 on the syntax, or are there cases where you would even consider surgery for a lesser score?
Yeah. No, that's a very good point. I mean, these kind of cases, if we see the
We can
tight
show the
disease,
IVUS.
yeah.
Yeah.
So we are going to show the IVUS, but yes, we do follow. But this case, did not make from cutoff of 33, so we did not have a consultation. But many times we do have consultation on these cases. But we felt in this case, probably not. With RCA and distal left main LAD are the one culprit.
Prox
Okay.
LAD, left main bifurcation. This is distal left main. And the long left main. Proximal part is well open. I will stop it. So first I check the distal left main cross-section area.
So key remains in the distal left main and the proximal LAD.
Yeah. So now we see the circle on the 10 o'clock. Now come proximally. So this is the distal left main.
Go back to distal left main.
Yeah, this is left main. Like here, the AI said 6.1 cross-section area. Looks like
borderline.
Yeah, like 180 degree of calcium. But area-wise, it's 6.1. And plaque burden around 60%.
And the contiguous plaque in the LAD.
Yes.
How does it look?
So this is a bifurcation. Now go inside. This is the osteal LAD. Here's also some eccentric calcium. Looks like nodule, but area is
get 1.75.
okay. So looks like osteal LAD area is okay.
Now go to the LAD.
Yeah.
That's LAD.
Then yeah, this is a proximal LAD, like almost 360 calcium and some calcified nodule in the proximal LAD.
Go back to the nodule.
Sure.
Oh, there. Yeah, you see it.
Yeah, I mean it's like small protrusion.
Mm-hmm.
Yeah, and almost 360 calcium sheet.
Okay, understood.
Yeah.
So same wiring wise, despite all the tortuosity, I just used the rotafloppy. We were able to wire with the rotafloppy wire and then did the IVUS on the rotawire.
Samin, totally agree with your initial statement that the lesion looks easy. It may not be. I mean, as imaging has demonstrated there, what is your feeling on the distal left main?
So very question. So the question is very important question. Is that once you are working on the osteal LAD and you have little beaking and plaque in the distal left main, what we learn now, don't think about putting a stent in the osteal LAD exactly. No, you cover the left main and give enough room for the stent in the left main to do the pot. So in this particular case, it has to be done distal left main and proximal LAD, although distal left main did not make IVUS criteria, which is either 5.5 or 6. It's a little more than 6, but there's a very tight osteal LAD and you cannot do the osteal LAD without taking care of the distal left main. So that will be our goal in this case, that we consider that as a single lesion from distal left main to the LAD, proximal LAD, and then osteal circ looks very good on the side view of the IVUS.
Yes.
But more important here is that treat this as a LAD lesion, and the left main just comes as a side. And in that case, that you give enough about 8-10 millimeter stent in the distal left main. So then you bring a large balloon to do the pot. There is a pot balloon available now, which does not have any shoulder. It's available in 3.5, 4 or 4.5. Problem is it's like double the price, actually 3 times, because regular balloon is $65 and the pot balloon is $250. So it's a 3-4 times higher. So therefore, we don't carry the pot balloon, but we did use a few, but we didn't feel much in terms of exact utility with the price. Yes, if you think very short left main or you put a very short balloon, because it's a 6 millimeter and no shoulder. So it's a good. But many times we put a 8 millimeter stent in the distal left main, so your regular 8 millimeter balloon works quite well. So therefore we don't use routinely the pot balloon.
Your acquisition cost of a balloon now is $65?
$65. That's it.
Unbelievable.
Soon, I
Unbelievable.
just talked
People
with a few
talk
times.
about inflation, huh? This used to be $800
Yeah,
25 years ago.
that's it. Yep. And now I said soon they'll be giving us free.
Free.
The same thing, the stents. Stent prices in last 3 years have really bottomed out. But the prices now become 450 for the stent. Now, the prices of some of the, while we are getting ready with the 1.75 bar, because the circular calcium or the Austral LED, we are using the prices. Let me tell you a few other prices. So clearly that I told you the the compliant, non-compliant balloon are between $65, $75. Then we have the scoring balloons. So they are about 600, 650. Then we have open NC, which is the double layer balloon, and that cost is very expensive. That's about $1,100. So those are the prices of the balloon. Now you go to further, you go to IVL, $4,700.
Right.
And then now you go to the drug coated balloon, is 5,600. Now only advantage is that both IVL and drug coated balloon are appropriately reimbursed. And same thing happened with the MCS, that you have a IABP, there is no extra DRG on that, but you have MCS device, although IABP costs about $1,700, but then you have a MCS device using Impella, cost about 25,000, but DRG goes up significantly, close to $100,000. So and same way, appropriate IVL, the companies which make it, I mean the insurance company which is reimburse. So those cases. No, this will be okay. Just continue flush. Yeah. So these cases, the appropriate reimbursement makes a very good sense. Now the same thing is happening with the drug coated balloon. Now majority of the insurance companies approve that. And other thing is the Medicaid still has not identified these procedures, including Impella. We actually don't get anything with the Impella. Now we have maybe the technical fault in this burr, that it cannot wire. We all have tried with every way, even the needle threader experts. Yeah, I can tell you over the years.
No, this is becoming very common now.
Yeah.
Especially 175 bar, we have not had. This is at least the 5th or the 6th.
Yeah, there is not a complete
we don't
hole.
Yeah, and the wire doesn't go.
Wire does not go.
The problem could also be at the distal end of the wire. But
no.
It's
always the bar.
Yeah, no, we saw that here. So what we can do, we can put
diameter of the burr is.
Yeah, see, it goes in but does not go any further. So probably something is stuck inside. So what we can do, close the flush now. So we can
tried all of that.
No, back. So now gather needle.
No, you cannot.
No, we can do. 1 second. Where is the needle introducer? Yeah.
Right there.
Yeah. So what you can do, many times you think some kink, and so you can put from the back end and your.
No, but you need this way, no?
No, I know. This. It will not come out from the end. So you're coming out. Come on, 1 second.
Oh, you mean there is some junk?
That's why I think
this is what you're showing is what you have experienced doing cases overseas where you have to be often creative and.
That's right. Now it will not come out from the tip completely, as you know, 0.014. Your wire is 0.009. So this could come out, not the front end. Just 1 second.
It may still come out.
Yeah, it should be able to come out.
0.014.
Only thing, there is not enough room now. 1 second. Yeah.
I don't think so. I think
it will come out. It will come out. No, it will come out. Yeah, see, it's stuck. Yeah, there is a
just
technical
the distal part. Yeah.
Okay, open a new bar.
Yeah, 1 second. Oh my God. One second. This has to be tight.
Please. I don't think anybody's.
I know, just one. I mean, you have to give me 1 minute to just go through this exercise. Otherwise, we just have to open the new one.
Yeah, so what?
Yeah, okay. Yeah, so it is stuck. Yeah, this level.
Open.
Okay,
It was a worthy try.
that's true.
Look, I think it's important because people often encounter this, and these are some tricks. How
Yeah.
why just
Now you pull
discard
the
the
wire back.
equipment?
See?
Yeah.
I knew that's going to happen. You have to rewire since the wire is back again.
You use the clip.
I know, of course, 7 French guide, no?
Yes. We are thinking that if there is an ostial
Dedicated
plaque,
to,
yeah, many times the plaque may move to the, you have the clip there if you need. The torquer, you are in the more septal. Yeah, good.
So, I mean, interesting question here for you. Have you ever used OCT for a left main?
Yeah,
I mean,
yeah,
distal left main you
distal,
can
yeah.
here since it's a long left main, but ostial is usually hard because you need a lot of dye to see the dye clearance. Now you see this is kinked, rotor wire
And you will
is
miss
kinked.
it. No, this will be okay. Yeah.
Okay, see?
No problem here. Make sure that
That's a
goes to the
total waste.
company.
No, we've been sending a lot to the company.
Came out? Okay. We can have the lights down a little bit now. All types of light. This one, yeah, good.
No, we don't want too dim.
Okay.
Okay, come.
Check the speed, always.
No, we don't.
Let's see that.
Bring this to us so we can see the.
Good. 150. We just show it, but as I said, you don't need to check that speed. And they are working on also that electric, just like our orbital. Let's pull back left main too far. Yeah. That you should not using the nitrogen and oxygen, and then just use the electric.
I mean, another 2-part question. I think we'll let Anu use the rotor, and then I'll ask you.
I just move a little bit. Yeah. And we did not use the 2 bar. What?
I'm pulling back.
Yeah, you need to pull back. Good.
Yeah,
we wanted to cover the distal left main. Yeah, good. That's okay.
Okay, good.
Yeah.
Get the run through wire ready.
Ready. Yeah. Yeah. This is the tortuosity part where you have to go a little slow, and that is why I use a 1.75 bar rather than 2.0. This case could have been a 2.0 bar also, but because of that tortuosity, we saw it in the LAO view. 1.75 is good enough.
Kiski, what's the diameter at the tightest area of the LED?
2.5.
Like 1.5 at the level of nodule. 1.5.
1.5?
Yeah,
Okay.
MLD. At the level of the small diag.
So people who are using imaging and want to understand what size bar to use. So if you go see there, show the diameter you're looking at it is.
Yeah.
That's where the nodule is, and look at that 1.5. So you cannot use a bar less than 1.5. So 1.5 may barely do some kind of a calcium modification, but ideally 175 bar would be very good. So that's one of the teaching point for people who are learning to use IVUS and use the bar sizing. That's the algorithm we have created also, both for nodule as well as non-nodule cases. Okay.
I mean, several questions here. The first is a two-part one. Would you also consider a
Yeah.
cutting balloon and orbital here? That's number one.
Yeah.
Okay, so but that I can answer first. Remember tortuosity. Our algorithm is also that tortuosity avoid the orbital. Although now they have the Viper wire flex, which may be a little better useful, but we try to avoid in the tortuosity. In this case, not. But I would say that you can use. But look at the circular calcium and thickness of the calcium. Anytime when you have those are the roti score, you have more than 270-degree calcium, then you definitely will have a trouble. You can use it, but you'll not be able to have a full plaque ablation modification that your stent will not fully expand. So if you ask me the second question, that can you use IVL in this case, our answer that is 100% yes. So not the cutting balloon as an initial strategy, not the orbital atherectomy as an initial strategy. Yes, we can use the IV, the cutting balloon after the rotational atherectomy. So that is what we have now. We have done the rotablation, and now we are going to use.
So here is this is
Yeah.
a very unusual
Second part.
question. I'm going to read it as it is sent
Yeah.
to me. How
Yeah.
to change the speed inside vessel?
Oh, this is the dial up from outside. We can use that from the dial. You have to have the tachometer, and then you can increase the speed. Now, I say different point, that if you're thinking that you are going to increase the speed is not the right thing, because you want to see that what is the deceleration, because deceleration tells you that how tough the plaque is, how much the slow flow or debris will be generated, and anything more than 5,000 is the limit. 5 to 10,000 is a little bit. That's where you have the open triangle comes on the display, and you get more than 10,000. This becomes the full yellow triangle. So open triangle 5,000 to 10,000, more than 10,000 is complete, and then of course you go beyond, then it becomes red light as a stalled. The question is, many times when you are doing a rotablation, technician not knowing it, when the RPM starts going down, they increase the speed. I say absolutely wrong. That should not be done, because that defeats the whole purpose. You want to see that you are not causing the uh, excessive plaque material ablation. So this is what you need to do. So clearly, do not change the speed. Speed you just set outside. If your speed is changing inside the lesion, that basically means it's the trouble with the lesion, and either you downgrade it, or you have to think about maybe it's going to the more adventitious. So the too much resistance. So as such, inside, once you have set going into the vessel of 150, 145, you should not change the speed. Rather, when lesion does not cross, we go to 180, because we know that original author idea was 180 for burr less than 2 and 200 plus in burr more than 2. This actually was,
Can you
I'm
show
sorry,
the
other way
iris on the
around.
screen?
Burr of the 2 plus 180, and the 200 plus
1 second.
in the burr less than 2.
Can
And
you show
those
the-
cases
okay,
are the
start to
one
work.
the clearly the used to have high speed in the past, and that caused a little more dissection, a little
lesion.
more slow flow and perforation. So we went down to
Lesion
the
is
slower
open.
speed. And therefore, but whatever
Stop
speed
it.
there is, it should be maintained, because that's your parameter, that how much resistance your body is encountering with the plaque. Because let's say the speed went down to 135, and somebody increased that speed to 150 again. That's a wrong thing. Because that basically means you have a lot of resistance of the bar. You went maybe too fast, maybe causing a perforation or tremendous slow flow. So now we have a
Two
3.5 balloon.
things I need to add for that. Can you change the speed in the vessel? You can, but it has to be in the segment where there's no disease, or area where you already have done your atherectomy, which I think in some of the cases we have shown that the burr is not crossing the lesion, come proximal, increase the speed, and then go back doing your atherectomy. That's number one. And cutting balloon is probably a no-no even in our algorithm, when you have 360-degree arc of calcium on the imaging, as well as if you see the tram track calcium on, it's the cutting balloon is probably not ideal. But can we use IVL? We can use IVL. It is just that would it deliver? Okay, we have had cases where it thinks IVL will deliver, but delivery of IVL also should be taken into account.
particularly this tortuous. Although
Yeah.
lumen wise you think that it could, but with that calcium and that tortuosity, I won't be surprised that IVL will not deliver. So what will happen if you want to do IVL? Dilate the lesion with a 2O non-compliant balloon at 20 atmosphere, then deliver your IVL.
Then all your purpose of doing any kind of atherectomy in calcium
No,
lesion
but
is gone.
IVL is okay. IVL is dependent on the balloon dilatation because it will
Yeah, it's
do the
shaped.
cutting.
Yeah, show the IVUS.
Yeah.
Did it do? Okay,
Yeah,
so
this is the
one.
level of the tightest, like a 360 calcified nodule part, but it's wide open now.
Yeah, so
Yeah,
1.5 became 1.75. So
Yes.
looks like rotational atherectomy has done its
Yeah.
part,
Shape
right?
the surface. Yes, definitely.
Yeah.
And some
It did a
revalidation.
excellent job considering the modification of the nodule.
Yes.
Yes. Okay, so what we can do now the question comes is that why can we just do balloon? Okay, so now the question comes, can we do high pressure balloon? Should we do a cutting balloon or should we do IVL? I think rotational atherectomy has done its job, but he just mentioned the word reverbation. Reverbation means that it has taken care of the calcium. It's the IVUS is not as in understanding the calcium modification as good as a OCT. We know that, and because of that, but from the imaging that we have, and I think one thing everybody has to learn during our live cases is you don't have Kiski in every lab, but he does a great teaching during these live cases, exactly how to understand the imaging. And I think more so we do that in our imaging live cases, but go back and show them what is it that you're trying to tell us, that rotational atherectomy has done its part. We don't need IVL and we can just go with high pressure balloon. Kiski.
Yeah. So this is the level of the severe calcium, like a calcified nodule. It was like MLD was like 1.4. After 1.75 allotted, now the MLD is 1.7. And they're like artificial, like a circle, because we did a loaded surface of the calcium and the calcified nodule. Now we don't see any like a protrusion. It means the surface of the nodule is like shaped,
Yes.
well defined. So we didn't do balloon, so we don't see like a dramatic fracture. But the area is like wide open. And actually, the severe calcium is very short length. The rest of them is mostly eccentric. So like we can expect the balloon will open. So I don't think we need the IVL anymore.
Okay.
And also the data we learned from the shortcut trial that after rotational atherectomy, that you do a cutting balloon or IVL. So the advantage basically was that if you did not do the rotational atherectomy, their IVL was better than cutting balloon. But if you have a cutting balloon, then probably should it be a routine strategy, you could do it. Yes, and then you can avoid putting a IVL based on the trial. So this is now we are 3.520 non-compliant balloon.
3.0.
3.0. Okay.
Go.
Yeah.
I mean, based on the vessels, should have been 3.5, right?
Yeah, vessel is 1.35, but
Go.
diffuse plaque and no
Yeah.
good landing zone. So yeah,
3.0 is okay.
yeah, it's safer, I think. But stent wise, if you
Down.
cross to the left main, bigger might be better.
I mean, I know we have covered it in a previous transmission, but for specifically for nodules, what do you think? Rotational ablation is better than IVL? A combination of the two? What is your overall strategy?
Wait till you get the results of the nodule shock. We have completed the trial of 120 patients and we have sent it to TCT as a late breaking trial.
Specifically addressing this, yeah.
Nodule.
100%, yeah.
Now, only question comes down to what we will not answer with the nodule shock trial is that whether orbital is better, because orbital has not been used in the trial. Yes. But yes, there's a lot of disease, lot of fractures, which is all right, which that's what you expect. And in this case, I think you can remove the rotor wire and put a wire in the circumflex in case we have to go back in.
Okay, so now let us, what we'll do is we need a longer. I thought 28 will be okay.
No,
so let's put a 33.
33.
3.0, 33 and get us a 3.5. Left main is 4.0.
Yeah, so
4.0.
do you think 3.0 stent is okay for left main?
Yeah. Can remove
so okay, so you want to put 3.5 low pressure. Okay, 3.5, 33 low pressure and a 4.08 high pressure.
Mid LAD was already dilated with the balloon?
It was. We did not go all the way down, but looks like there is a axial plaque shift. Okay, get the fielder wire. Let me just wire the
Look.
So of the ablative technique, what we can say based on the various trials, that calcific lesion, rotational atherectomy, and IVL have a similar MSA and similar acute success, except the IVL will have a slightly lower perforation rate. But MSA, everything else, the dissection, malposition, maybe a little less in the IVL. Then the for the purpose of the nodule shaving. So some data support that orbital may do a better job, particularly if there is a calcium around the nodule, because you'll shave it better. But we didn't see that, so that's not our algorithm. Is that in the nodule you have to use the orbital. So we do not have that even our imaging, and we actually did the study, and nodule actually IVL works very well for nodule. Our non-randomized data, we published that, actually gave you a bigger lumen, but now with the randomized data, we'll learn from the nodule
Some
shock. So, but all can
die.
be used. There's no question on that point. The orbital, but now the question then comes that we'll know that once you use the the cutting balloon alone in this calcific lesion compared to IVL, the lumen MSA was lower. So cutting balloon basically lost in these cases against IVL. But if you did rota, your cutting balloon and IVL will have the same outcome. So that's a good advantage which we learn from the study.
A
What we
wonderful
talk,
job with the wire there.
yeah. So I think if you had asked me, I would not have wired, I would not have imaged the circ with stent across, but for the sake of our
everybody's
viewers,
teaching,
we
yeah.
will do it.
Yeah. Good.
Let give the IVUS. So let's just quickly look at the ostium of the circ. That's question number 1, and I think we have mentioned that, and we also have discussed multiple times is understanding this arc of calcium around the nodule. That's the key. We can show you the nodule shock. Do we have that slide?
Yeah, one slide of the nodule
Yeah,
shock.
and then if you can put that algorithm which we had
Yeah,
based on
you can
our previous experience.
So this is an algorithm in the slide.
Okay, you wait. Let me do the imaging, then
Sure.
you quickly go there. The stent is ready. Only the ostium, okay?
Yeah.
Right there.
Reason why
Check
we
the
are now
image.
encountering.
Wow.
Go
Okay.
ahead, Kiski.
Yeah,
Kiski,
I
go ahead.
start pullback. This is a proximal circ. It's coming. Okay, I check the area, but looks open. Then
Are we
long
back in the left
main.
main?
Yeah, this is long left main, and
Okay.
I stop it. I check the osteocirc. Yeah, this is the bifurcation. Yeah, yeah. Sometimes the air doesn't work. 1 second.
Okay.
Yeah, some estimated area
This is good lumen.
Yeah.
Yeah.
Yeah, area like 6.
6.
Yeah,
Good.
the osteocirc. Yes.
I would say 7 because I think your circle is coming inside.
Yeah.
You know,
Mm.
keep it outside.
Of course, it's not like a real coaxial because angulated circ, but it looks like yeah, more than 6.
Okay.
And we also actually forgot to introduce our fellows, Angelo Oliva, which is our hybrid fellow, which is the research and intervention,
not
and then
which.
Pavan. Vadera is our international fellow, which we are 9 of them, and the nurses are same, Will and Kim, and cardiovascular tech, Asif and Hakim, and of course the imaging is Kiski. And we are ready now. What's the plan now?
No, we are going to stent from left
Good.
main to
Okay.
LAD.
Good. So we are using a 3.5.
33.
Huh?
And let us see. I mean, eyes are telling me 33. Let's see what the imager is telling us.
Because the initial plan was from the septal, but now we go more distally, so we don't have that distal image. So now it depends on the eyes.
Okay. So here now, even Kiski is telling use your eyes.
I mean, we don't have IVUS image, so.
408 ready?
Good.
And after that, you can start your lecture.
Maybe a little short. Okay,
Mm.
take a picture. You can go to 38 because remember you had to have balloon hanging in the left main in
Go.
order to have, yeah, 38. You have to cover. There is no reason for us to do.
Where?
No,
Now, do
distal.
you want a left main that much?
Yeah, definitely. You need about 6-8 millimeter for the pot. Or you can go 2 millimeter further if you want to do.
Yeah.
Yeah.
I went in. Okay, now give
Yeah, I
dye.
think you should be able to cover it.
Okay. Good.
Looks good.
Okay, go.
So this is a book. 3.5, 33,
Yeah,
and
low
yeah,
pressure
yeah.
because it is
Yep.
not
Yeah.
yes.
So we are just
We are
going
going
10
at 10.
atmosphere.
Yes.
Yep.
Okay. Down.
And I see that a lot of people just go up and down. No, you have to let the pressure transmitted to the stent balloon. I mean, the
No, what they do
maintain
is
at 10.
oscillation.
Yeah.
Oscillation
Or
it does
just go
not work.
10. Yeah.
Yes.
So now you left it. Your does not go down means you are fully inflated, and then go negative. We actually did the oscillation trial in the with a balloon called crack, and the oscillation did not work.
Okay. Quick picture.
Yeah.
You see the significant EKG changes?
Nice.
Wow.
Oh, diag is gone.
Good.
I think
Let's
it was
do
a
the
good
left.
idea to put a wire down the circ.
You want to go to some different view, Professor?
Okay,
Yeah.
you can. Wire came out anyway.
Wire came out already. Good.
Yes. Okay. It's telling us no need. Okay, let's see.
Just 1 second. Where? Yeah. Good. Want to give a little nitro.
Oh, the diag. That's the
Gone.
problem. Yeah.
Very small diagonal gone.
But
Yeah.
massive EKG changes
Yeah.
due to the diag.
Now take a picture now. Make sure circ is good.
Circ is okay. It's a
Circ is very
diag doing that.
Yeah. Okay.
I think we'll leave it alone, no?
Right
Diag.
now. Let's see. It should come back.
Let's post.
Yeah.
Okay, give it to me. Yeah, 408. Get us a nodule shock
Yep.
slide if SS has it.
Yep. Oh, yes. Maybe side at side.
Yeah. Let's slow. 10 more minutes.
Okay, go up. 18.
Go next, next, next.
Okay, good.
In this case, 10 more minutes. 10,
Done.
15. Yeah.
Now when I go inside, go 12. Okay.
Okay, nodule shock is in the screen.
It is in the thing. Okay, go up here. Little bit. 10, 12, 12. And then, okay, good. Down.
So, I mean, if you look at just that image up there,
Yeah.
the
Go up here, 12.
cost notwithstanding, a dedicated pot balloon is a very good idea.
That is
Okay.
that definitely. Actually, India believe in lot of pot, repot and all multiple
What
times,
happened
and
in the
they are
rooms?
using quite a bit.
Mm.
Their cost is very minimal.
Right.
It is regular balloon is there like 25,000 rupees, and pot balloon is 40. Here is a 3-4 times. That's a different story. But there's massive EK changes still.
Mm.
Let's give some vasodilator.
Let me see if we
No,
can
just
wire
put the
that
vasodilator
diag.
first. Yeah. 1 second.
You give vasodilators.
Yeah. And
Let
get
me
a
see.
put the balloon a little more. I mean wire in the LED. And it was not a very big septal. I'm big diagonal, but it's there.
Calcified. Oh, there it's coming back a little bit.
You have to bring this out and make a special curve.
Mm.
Sharp.
Okay, take a picture now.
Okay.
See a little.
Now, there is no contraindication on this case.
Hmm.
If you want, you can get a 1 bolus of integralin, because remember the side branches in all the trials have shown with the 2B3A, you have less occlusion of the side branch. Although this will be a little different now, you're using it as a bailout. But 2B3A, do you help decrease side branch? So you order 2 bolus of integralin. What we do is never infusion. You want a whisper or some different wire. And otherwise, just use a 2 bolus of integralin 10 minutes apart. And that will definitely retrieve your side branch, but had to be associated, make sure there's no complications or patient comorbid condition like CVA, thrombocytopenia, because those all will create more trouble. But this guy, this patient, I mean, it's dramatic change in the lead 3, which is a little unusual. But I know one thing is that you have to make a different curve, because this your curve was the circ curve.
No, no, but I think it's still okay. It's going to that, but the question is, do you need whisper?
No, or do you want to with the course supercross?
No.
90, because
I don't think you wish. Oh, because of the EKG changes.
Just looking at the changes in lead 3, that would probably suggest a circ, no?
No,
Yeah.
but circ is very good.
Not on
But
the
circ
Just
was
the
the
line.
flow was
Looking
very
okay.
good, circ.
Mhm.
Yeah.
Yeah.
But you're right. It will tell you that maybe that's the case.
What?
That's circ, but not in this case.
Uh-uh.
So we have seen the circ.
It's going to the circ easily.
Yeah.
Yeah. You should start your lecture, SS. It's
Okay.
already like end of the how to image and be done.
All
with
right.
it.
So basically, what we are going to do, that we're going to go through, Dr. Keen is going to retrieve that diagonal branch which is causing key changes. Now, can we find out the patient having chest pain also? But definitely get a 2B3A. All right. So I know patient was on clopidogrel. Maybe whatever the PRU is another issue. There is no, all the patients 81, but there is no contraindication in giving any of additional strong antiplatelet therapy. Okay, so let's go quickly while they are trying to retrieve the diagonal branch. What we are going to do is some of the interventional publications with the eye care OFDI, which is actually really to this case, applies to this case, Prospect 2 trial, when they did an analysis of CRP with high-risk vulnerable plaque. Then OCVC bifurcation trial of the drug-coated balloon, Orbita CTO trial, and clopidogrel versus aspirin post-PCI in long term. Then we have the patient, the outcome after various coronary physiology values, because many times you have the discordance between FFR and non-hyperemic pressure ratio like IFR. So let's go quickly to all of them one by one. Eye care OFDI is the trial of comparison of the IVL versus rotational atherectomy in calcific lesions. So all patients had a OCT. So this is very clear. Patient, if they could not, what they did is, once patient was there, they put a 2 balloon in every case. Once it is crossed, then they are randomized. If not crossed, patient was a screen failure. And after crossing, did the OCT and IVL and rotational atherectomy 1-to-1. They gave 30 pulses. So the more you could give, but minimum 30 pulses. After rotablation, do a non-compliant balloon, then DES, and then you do a final OCT run, which called OFDI. And the primary endpoint was minimal stent area, and the clinical endpoint was 30 days and 12 months target lesion failure. So basically, you can see usually the calcific lesions, not much difference in terms of baseline characteristics, but definitely differences were in the procedure point of view. One of them is pre-dilatation. Much pre-dilatation in the IVL group compared to atherectomy. So then, other was the final, what was the final result? The minimal stent area was 5.9 versus 6. Exactly identical between two strategies. So that was the primary endpoint. The another difference they found was the major malopposition, which was higher with the rotational atherectomy compared to IVL. Some studies have shown that. And this basically, overall, these are the individual endpoints. No difference, as I mentioned, put it together. So clearly, the major malopposition, other things like stent thrombosis, stroke, and all, and bleeding were numerically actually lower in the rotational atherectomy group, but no significance. So only significant was the patient with malopposition, and the other point with the stent area completely identical within two. The second trial was the trial of the Prospect 2, which relationship of the high sensitivity CRP to high risk vulnerable plaque after non-STEMI. And basically they found that you have a gradient of the CRP, low, intermediate, and high, less than 1, 1 to 3, more than 3, and they're associated with lesions with a high plaque burden, more than 70%, maximum LCBI of 324. So clearly that higher the CRP, higher is the vulnerable plaque burden with this. This is the nice relationship of the LCBI with the CRP. So higher the CRP, higher is the LCBI, which is representation of the vulnerable plaque. Then factors which predictive of the non-culprit lesion related events. Just want to say in Prospect trial, after the culprit vessel PCI of the non-STEMI, all other vessels were imaged. So these are all the non-culprit vessels, and follow up to 1.7 to 5 years, and basically learned that the CRP and patients with high risk lesion features are the two important predictor of subsequent event. And so this actually put it together in one page in terms of all the data which we have shown. Then so basically CRP has both focal and pan-atherosclerosis. Then question is what you do. CRP should become, what we learned from the Prospect, it's an additional marker which really tells us, and more importantly, many times you have imaging, and if you have vulnerable plaque, and that's the other question comes. You have a lipid-rich plaque, non-culprit, but many of them have a negative FFR. What you should do? We know that that plaque has a high event rate, but there is no data to support at this time that that lesion should be intervened. Then for the bifurcation stent balloon, it was a bifurcation study. After the stenting of the main vessel, they did a kissing balloon in every patient, and half of them got the DCB, other half got the non-DCB. But kissing balloon was done with a 2 non-compliant balloon in every case. And in the DCB group, it was the DCB. And what they found, these are the lesion characteristics usually, and overall features were not different in terms of the majority of them were not different. The only different basically was as you can see, the main vessel late lumen loss was significantly smaller or lower in the DCB group compared to non-DCB group. So there basically the difference was 0.21 versus 0.36. For the side branch also, see the side branch late loss is lower compared to the non-DCB group, and this actually was also significant. So these are the individual endpoint. The restenosis of the side branch defined on angiogram between 6 to 9 months, associated with lower angiographic restenosis 8.1 versus 18.3. Other endpoints were numerically in favor of the DCB, as you can see here, but not significant. But that's basically showed that overall the DCB did quite well in terms of for the side branch. And there was the OCT also sub-study. There show the same. Lumen loss means DCB actually what it did, not the lumen loss, rather there was a negative or positive remodeling. The lesion, the vessel was bigger. So you see the vessel healing. As you can see here, the DCB and non-DCB group, all at the follow-up, p-value is 0.042. It was mean was 0.14 versus minus 2.15. So it did not only it did not shrink, rather dilated. So this is actually have been spoken about the positive healing effect of the DCB, and this is what trial showed. And everything is put together in this one-page study, and so then. So clearly, the adjunctive side branch DCB treatment after KBI showed no adverse effect on main vessel stent healing, and rather actually lower ISR, and possible signal towards preservation of the side branch lumen. So clearly, the duct-rotated balloon coming more and more in our side branches. OCT definitely helped to get the final data analysis. Then, what about the placebo-controlled trial of CTO. The Orbiter group, what they do is, whatever the trial point is, both group of patients get the same thing. They get the angiogram. Catheter goes up to the coronary, except patients who are medical therapy, does no control group, just comes out without putting that therapy, whether it's a stent or balloon, whatever. But if and other group will get all the way the treatment, and they wait, so that it doesn't look like that quick quick case is that the no PCI was done. So they are very blinded and a superb the investigators which keeps coming back with the individual data point. So this was the Orbiter CTO trial where there is a one vessel occlusion, and we know that CTO now recanalization is 2B. Why? Because we have 5 major trials which have shown no long-term benefit. And so that is the major reason. So what they did is their usual pattern, that after the initial assessment, baseline characteristics, you tell the patient on their iPhone, able to tell your angina status, that whether how many angina episodes, how much they last, and so on and so forth. So same way, the blinded follow-up. Then at the level you go inside the coronary, did the angiogram in those patients, and then as you can see, one group got the stent, another one just came out without putting a stent. And then the patients are follow-up. This is what done. Primary endpoint was angina symptom score. And what they found, and this is the Orbiter trial data, that lesion characteristics, and all of them, I would say that comparable, a small number of patients, 1 to 1 of 50 patients. But what they found basically is, you can see success rate, one patient could not cross. So therefore, success rate become 96%. And this is that angina, as reported by patient. CTO PCI improved angina symptom score, and PCI led to additional 30.6 days free from angina. So clearly, that PCI did a better job. It improved the angina frequency, and although there was no difference in the anti-anginal use, but clearly angina frequency decreased, then angina symptoms decreased, and patients were also free of angina status. And as far as the CCS class concerned, they're also improved in favor of the PCI. Therefore, the symptom, the CTO PCI versus placebo angina symptom score, daily episodes of angina, standardization unit or anti-anginal medications, all were shown, and this is what put into the one-page trial. So in patient with symptomatic single vessel CTO PCI improves angina beyond placebo. And this is what the first of the trial with nice editorials. As you can see, the biological signal of recanalization, orbital CTO opens the door, but still the guideline remained 2B. Selected cases could get the CTO PCI. The last one is the clopidogrel versus aspirin monotherapy, which have been one of the top advances last month in actually June, our CCC symposium. It was the 9th advance, the one before the last one. Last one was the imaging. And basically, question always comes that what you do. Patients had received the duration of their DAPT, 6 months, 18 months, whatever is there. After that, you continue aspirin or you continue clopidogrel. So this is from Korea. Korean, they have their own, just like ACC and CDR, they're all reporting, and they've found that if you have clopidogrel monotherapy or aspirin monotherapy, that clearly the clopidogrel monotherapy was associated with better, lower MACE, lower death rate, lower MI, lower stroke, lower major bleeding, and importantly, GI. So anytime you have issue with the GI, clopidogrel will do better job than the aspirin. And this is put together very nicely in one page data. So therefore, you can make it a point, and I do start doing it now for last 1.5 years, that after 1 year, I'm not stopping the clopidogrel, I'm stopping the aspirin, and so. So therefore, the last one is our focus review of the month about discordant physiology. So what we know, there are many tests we have, physiological lesion assessment. One is we call non-hyperemic pressure ratios, which is PDPA, IFR, DFR, RFR, and all these, the DPR and constant resistance ratio. Then we have angiographic-based, angiograph-derived FFR, quantitative flow ratio, micro QFR, vessel FFR, coronary angiography derived FFR, angiographic derived IFR. So these are the angiographic based. Then a 5 FFR system using CTA. So FFR CT, cFFR, ctFFR, change in ctFFR across the lesion, and ctQFR, which is the quantity flow ratio. The several systems using intravascular imaging, virtual flow, ultrasonic flow ratio, optical flow ratio, and optical ultrasonic flow ratio. So all these are the various physiological tests which we have at present in order to guide our treatment in many cases. And what we learned is, this is a nice J-Pride registry which showed that about, if you take a percentage wise, the patient will do a study and we assess them with FFR and IFR. 44% will have negative FFR and negative hyperemic. So it's a concordance. Good. These patients do very well on long term, and you defer the PCI-HC in the majority cases done. Then second group will be both positive, FFR positive, and the non-hyperemic ratio positive. This is 36%. So if you combine them, 80% patients will have concordance. Concordance positive, concordance negative. Now, this is the group which we know a lot has been written. But what if you have FFR positive but IFR negative? Or your FFR negative, but IFR is positive. Those makes about 10% each. And question always remains. Yeah, the question always remains that what you do in these cases. So basically, is this discordant studies have shown that this discordant results, the patients don't do well compared to FFR negative or hyperemic negative. So clearly those patients don't do well, and therefore what you need to do in these cases is to study what the region is. And there is a lot of literature now, and what has shown that once you have focal CAD, and this is very nice illustration of the FFR on the top. Because of the flow abnormality, you create hyperemia, you have a more FFR difference, as you can see there. But once your diffuse CAD, which gradually increases, there is not decrease in the FFR, but overall, in the end, you'll have a decrease in the overall IFR or physiological, non-hyperemic physiological data. So this is basically we learned. And so what also have done, that you have FFR positive and IFR negative, or FFR negative, IFR positive. So first group, FFR positive, they have a higher pressure gradient across the lesion. Compared to IFR positive, with FFR negative, there is a slow decrease in the gradient. There is not a high gradient across the, we call pullback, and they call it a PPGI, pullback gradient. And therefore, FFR positive, IFR negative is the focal disease. Then FFR negative, IFR positive is the diffuse disease, as has been shown with this study. They also showed that once you do revascularize these patients, it's all questionable because there's no guideline. So if you are discordant, FFR positive and IFR negative, the revascularization does the better job. But if you're FFR negative and your non-hyperemic is positive, so those patients actually don't do well in long run. They have higher complications, as you can see here. And revascularization does not make a difference in those patients. So with that note, there are many data, as you can see here, that IFR positive group is associated with even slightly higher, there's another analysis, that mortality. So your FFR negative but IFR positive speaks for a long-term bad disease. So question is, maybe those type of patients should be revascularized. And this is where I think the question happened in the defined flare. When at 5 years we learned IFR negative patients had a higher mortality. And so with that note, this is the latest data came, outcome of the lesions with discordance between FFR and non-hyperemic pressure ratio. And as I said, these are the various studies which they encountered. And the outcome basically showed in various of these plots. That key is that some concordance, some discordance, and if you can put it together, that basically primary endpoint of these discordant, they actually do a bad outcome compared to the regular way. And if I put it together, it's very simple, that patients who have primary composite endpoint of concordant negative physiology, and you compare them, either FFR positive, FFR negative, or corresponding negative positive, they're associated with more death, myocardial infarction, or revascularization. And same way, that if you have the in terms of secondary endpoint with a negative physiology, that your positive and negative is just again associated with higher death or MI. So just to say, lesion with discordant physiology associated with increased rates of death or myocardial infarction compared to both being negative or both being positive. So therefore, we had to think about the depth of PCI in these lesions are associated with a poor long-term prognosis compared to negative physiology. There may be a benefit of revascularization FFR positive, IFR negative lesions, which require further investigation. And of course, that is what you want to do. The borderline lesions, probably you should do if FFR positive or IFR, I mean, both are FFR negative, you should do the hyperemic and then see where this patient fits in. Because if it is positive, maybe those patients should get revascularization. We still have to learn that whether revascularization will benefit those cases. Another thing which has come up nowadays is the high risk plaque. And we know that many high risk plaques are FFR negative. But what do you do? Because you see that at follow-up, about 6-7 years, so 20% event rate if you have the high risk plaque versus if you did not have a high risk plaque. And this happens particularly in first 2-3 years. So therefore, it's a trouble. FFR negative, but you have high risk plaque. In these studies, they did not do the non-hyperemic pressure ratio. So IFR was not done. Maybe IFR would have been done, and if it was positive, that speaks for the bad outcome in the long run in these cases. So we have to think about what to do besides giving aggressive medical therapy in this patient with a high-risk plaque. So let's complete similar MSA take-home message of international publication and discordance physiology, similar MSA on OFDI and TVF between RA versus IVL in severely calcific lesion, so similar outcomes. Then high baseline CRP associated with high risk vulnerable plaque and pan-atherosclerosis. Then DCV of side branch is superior to non-compliant balloon with main vessel DES in the bifurcation lesion. And then one vessel CTO PCI is better than placebo in reducing angina and increasing angina-free days. And lastly, in cropatical or aspirin monotherapy, post-stable for efficacy and safety. So 2 thumbs up. So then the small group of patients who had discordance between FFR and non-hyperemic pressure ratio with the NPHR, and defer of PCI is associated with worse long-term outcome compared to concordant negative physiology. And this is where the issue is, because there is no guideline. The guidelines are FFR negative, IFR negative, don't do anything. But we learn if there is a discordance, if you both are negative, fine. But if there is a discordance, they have much higher event rate. So therefore, we have to think about these cases. And many times we know our negative physiology, patient comes back with the event. So these patients have differing mechanism at the lesion level, focal for FFR positive, diffuse for hyperemic positive. Studies have shown that FFR negative, but hyperemic ratio positive lesions are associated with higher adverse outcome, including mortality, despite revascularization in some. Lesions with FFR positive but hyperemic response negative have higher event rates, which may benefit from revascularization. This strategy, whether you should recommend those cases that FFR, your IFR negative, then you do FFR become positive, should they get revascularization? It need to be studied by some randomized trial data. We have just the non-randomized group. So we go to 3 questions now. Following are the true statement regarding the results of eye care OFDI trial comparing IVL versus rotational atherectomy, except means which one is wrong. Similar TVF, similar death rate, similar MSA, similar major malopposition, similar stent thrombosis. Clearly we showed the only parameter different was malopposition, which was higher in the rotational atherectomy group. So that's a wrong statement. Second, following are the true statement regarding the bifurcation, the drug-coated balloon trial comparing with a conventional balloon after kissing balloon. All cases they had a kissing balloon. Then they have one group had a DCV, other one did not. What was the true statement, except which one is the wrong? The similar MACE rate, similar restenosis rate, similar side branch and main branch TLR, similar PCI related complication, lower late lumen loss of main branch in DCB and non-DCV group. So clearly we showed that lower late loss in the main branch and side branch with the DCB, and also angiographic restenosis was lower in the side branch DCB compared to non-DCB group. And this, I put it, usually we have 5 answers, but this one, since this combo can only 4, that based on the outcome of various physiological parameters, which discordant following physiological group has the worst long-term prognosis. the discordant. So we know that if you're both positive, both negative, they are cordant. You don't have to worry about. If discordant, we learn that FFR negative and hyperemic ratio positive have the worst long-term outcome. With that note, I'll stop the presentation and we'll ask Dr. Keeney where we are with this patient. Anu?
Can we show the IBUS? So that's where we are, like
Yeah.
distal edge, proximal.
Yeah,
Right.
Maximus landing on the plaque, but stent is very expanded. MS is mid LAD 6.5 at the level of the diag. And come back to the left main. MSA of the left main 10. The proximal edge is also some smooth transition to the plaque. So no major malabsorption, no major dissection.
Okay, but can you see the level of the diag? It's probably 10 millimeters from the
Yes,
septum.
this is exactly the level of the diag. I see some like conduit, but maybe some septum here. So that's why it looks like it's occluded. And actually it's,
You think there's calcium?
yeah, most severe calcified lesion, the diag was there and it's occluded.
Calcified plaque.
Yeah.
That plaque shift with calcium.
Yes.
That's probably the reason.
Yeah.
So the regular wires, look at that. The regular wires, which was a fielder, this is a whisper. Then I even tried a fighter wire, because it is tapered 0.08 at the tip, thinking you need a, it did not have a lot of, tip load, but since it was tapered that it may go through that. But finally, the only wire that we could get it, see there, it was facing the right direction. So you cannot, what it's trying to tell us is a hydrophilic tip, polymer jacketed hydrophilic wires were not the ideal wires here because of the calcified lesion and probably the plaque, which was calcium as well as a lipid occluded that vessel. So then we got the Miracle 3, not 6, which we normally use for CTO, Miracle 3. We were able to get it. So if you see here, right there, yeah.
No, outstanding, outstanding. At this moment, I'll also ask a question which came as you were doing this. Recrossing through stent struts, any specific wires or specific wire shapes that you prefer? And this is directed straight at you.
Yeah, so I think I went through all the wires.
Right,
I'm asking Andrew there to give us a slide. Yeah, you can show the slide, but more important, I went through all the wires, but the curve wise, remember if we are doing a L curve to get into the circle, that's why I think Dr. Sharma was mentioning, take the wire out and make a shorter curve. So you probably need a shorter L or a C curve to get into the diagonals. So if where is the wire? No, I know. Where's my wire? Yeah, I can see that. I'm trying to show them the shape. They want to know the shapes. Yeah, if the wires are still here, any of the wire that is still. So if you can show me the ceiling camera. So why is it important that you go back to the hydrophobic tip wire when the hydrophilic wire? So why hydrophilic wire is the first thing that you think, since it's hydrophilic and you have the stent strut and you have to go through the stent strut into the side branch, you think hydrophilic wire will easily find its channel. But in this case, because of the calcium, just being a hydrophilic wire did not make its effort. So we definitely needed a hydrophobic wire, because hydrophobic wire, are they showing the ceiling, will keep the curve, so this is the kind of curve you would like. You see that? Are you able to see it now? Yeah,
very nicely.
A small L to a C-shaped curve, and exactly that's why I took that picture to show you. Look at that and this is exactly
show
what
the fluoro also on the side.
Okay, now you can see the tip. You can see the tip. Now show the fluoro. Yeah. See there?
Yeah.
So that was that. And of course, I mean, the fingers matters. We were able to get there. And so here what happens is, since the wire is dark all over, you're not sure. But the way, if you see how the diag, you don't see it, how the diag was before, we knew we are in the diag. We didn't have any PVCs. And you can see this little dye staining at the ostium. So we know we are in the diag. So because that's another thing that we have to be careful. It is a stiffer wire. We have gone into the side branch. Are we in the side branch or are we in the pericardium? So before you dilate, you got to be 100% sure that you are in the vessel, not in the pericardium. So the regular 1O balloon, the smallest balloon that we carry is Sapphire 1O. Even that would not make it because of the amount of probably the calcium and the way the wire crossed it. Also, it could be because normally when we say the wire does not, balloon does not cross into the side branch, pull back, go into a different strut. We can't do that in this situation. We did anchor. The only thing that was left is try a micro catheter, and we didn't want to be that aggressive here. So we took out the wire and took a nice picture, and the diag is back. You see that? No EKG changes. And then if you see the, EKG is back to normal now, not EKG changes.
Yeah.
The lead 3 actually got better, and he does not have any chest pain. So I think it's telling us not to get too aggressive in this situation, because then there's a risk of destroying the LAD and left main work that we did. Because every time you're trying to go through with a new wire, new device in the freshly placed left main LAD stent, there's a risk of, guide is way away, but there's a risk of LST or some changes that we will make in the main vessel stent. So I think since EKG is back to normal, it's time to say we can stop here.
And it's not a very big vessel, diffusely diseased, and we give 2B3 or no?
Not yet.
Intensity
After
not
we
yet.
close, we give it.
Yeah.
Because
After going
closure
through,
is
yeah.
also very important.
Yeah.
Yes.
So at least, so that just the flow, even TIMI 1 flow,
No, this
eliminated
is
those
a
EKG
good
changes.
2.5 flow, but there is disease in the diagonal, but I think we are okay.
Okay.
So these are the wires that I wanted to go through. So we carry Miracle 3. If you see there, tip load is 3. If you see that, it is not tapered. Okay. So hydrophobic coating, like I meant. So it's very important. So the shape is maintained. We carry 3 and 6. So, we have mentioned this in various of our live cases. Try to have 1 or 2 of these various wires, familiarize yourself and use them in a couple of cases so you understand how this wire works. Anything else you have? Yeah, fighter. Yeah, so this is the other wire, fighter. Usually I like to use them when we are doing circ to get into the OM. So Boston Scientific wire. So if you see the tip is 0.009, so it's nice and tapered. So tapered tip is what that is important. It is a polymer jacket and hydrophilic coating. So that's why I meant when you have to go into the side branch through a stent stud, this kind of tapered wire tip with hydrophilic coating could help us, but it was not that helpful. But I think one case in the live case we have shown to cross the side branch using the fighter wire. So various preferred uses for people. You see that tortuous vessel in this case, it was tortuous before we started, but now we have stented it. You can see where it can be used. And what's the next wire you have?
No, that's fine.
No, fielder, they're all normal wires. But I think the specialty wires we used were fighter as well as the Miracle, which we showed why we used it.
All right.
Anu,
So
so many practical tips. Samin, great presentation. Congratulations for your new announcement and appointment. We conclude here, and we'll see you on September the 15th for the next session.
Thank you.